Pericardial disease, issues affecting that sac around the heart, starting with acute pericarditis, the inflammation of the pericardium.
Right. The key symptoms are typically chest pain, but it's often sharp and pleuritic, meaning it worsens with breathing in or coughing, and classically it's worse when lying flat and improved by leaning forward.
What else might you find?
You might hear a pericardial friction rub on auscultation, a scratchy, grating sound with each heartbeat, sometimes having 2 or 3 components. And the EKG characteristically shows diffuse ST segment elevation across multiple leads, often concave up, smiley face, and frequently PR segment depression as well, which is quite specific for pericarditis.
What usually causes it?
It's often idiopathic, presumed viral, but it can also be caused by other things like autoimmune connective tissue diseases, lupus, rheumatoid arthritis, kidney failure, uremic pericarditis, cancer, radiation therapy, trauma, or occur after a heart attack. Drusseler syndrome, so less common now.
How is it treated?
Treatment focuses on managing the inflammation and pain. High-dose NSAIDs like ibuprofen or indomethacin are the mainstay. Aspirin is preferred if the pericarditis occurs shortly after a myocardial infarction. Colchicine is usually added to the NSAID therapy and continued for several months, as it's been shown to significantly reduce the risk of recurrence.
What about steroids?
Glucocorticoids, like prednisone, are generally reserved for refractory cases that don't respond to NSAIDs and colchicine, or if NSAIDs are contraindicated, or for specific causes like autoimmune pericarditis. We try to avoid them if possible, as they might increase recurrence risk.
And the more dramatic acute pericardial issue, cardiac tamponade. This sounds like a true emergency.
It absolutely is. Tamponade occurs when fluid or blood accumulates rapidly or in large volume within the pericardial sac, increasing the pressure around the heart to the point where it severely restricts the heart's ability to fill during diastole. This leads to reduced cardiac output and potentially life-threatening shock.
What are the classic signs?
The classic physical exam findings are known as Beck's triad. 1. Hypotension, low blood pressure. 2. Elevated jugular venous pressure, JVP, with distended neck veins, often with a prominent X descent but blunted Y descent. And 3. Distant or muffled heart sounds on auscultation. You might also find pulsus paradoxus.
Explain pulsus paradoxus again.
Pulsus paradoxus is an exaggerated drop in systolic blood pressure, typically more than 10 millimeter Hg during normal inspiration. It reflects the increased interdependence between the right and left ventricles when they're both being squeezed by the surrounding fluid. Inspiration increases right heart filling, pushing the septum leftward, further impairing left heart filling and output.
What does the EKG show?
The EKG and tamponade might show low-voltage QRS complexes throughout, and sometimes electrical alternans where the height and axis of the QRS complex literally alternates from beat to beat. This is thought to be due to the heart swinging back and forth within the large fluid collection.
And echo.
Echocardiography is key for diagnosis. It shows the pericardial effusion and, critically, signs of hemodynamic compromise, like diastolic collapse of the right atrium, the earliest and most sensitive sign, and right ventricle. Treatment is urgent drainage of the pericardial fluid, usually via pericardiocentesis, inserting a needle into the pericardial space, often guided by echo. And a crucial point: diuretics are generally contraindicated in tamponade, as they reduce preload and can further decrease cardiac filling and output, worsening the hemodynamic collapse. You need volume to maintain filling pressures against the external compression.
What about the chronic version, constrictive pericarditis, where the sac becomes thick and rigid?
Exactly. Constrictive pericarditis is a result of chronic inflammation leading to the pericardium becoming thickened, fibrotic, and sometimes heavily calcified. It effectively encases the heart in a rigid shell, severely limiting diastolic filling of all heart chambers.
How does that present clinically?
Patients often present with symptoms and signs predominantly of right-sided heart failure because the right ventricle is thinner-walled and more susceptible to the filling restriction. So fatigue, dyspnea on exertion, peripheral edema, ascites, abdominal swelling, enlarged liver. A key finding is markedly elevated JVP, often with a prominent Y descent, rapid ventricular filling hitting the rigid wall, and frequently Kussmaul's sign.
Kussmaul's sign.
A Kussmaul's sign is a paradoxical increase or failure to decrease in the JVP during inspiration. Normally, inspiration lowers intrathoracic pressure and increases venous return, causing JVP to fall. In constriction, the rigid pericardium prevents the right heart from accommodating this increased venous return, so the neck veins distend further. You might also hear a pericardial knock on auscultation, a high-pitched sound occurring shortly after S2, representing the abrupt cessation of ventricular filling as the heart hits the rigid pericardium.
How is it diagnosed?
Diagnosis can be challenging. Chest imaging might show pericardial calcification, though not always present. Echocardiography shows pericardial thickening, abnormal septal motion, septal bounce, and respiratory variation in flow velocities. Cardiac MRI or CT can better assess pericardial thickness. Sometimes right heart catheterization is needed to confirm equalization of diastolic pressures across all four chambers, another hallmark of constriction.
And the treatment.
The definitive treatment for chronic constrictive pericarditis is surgical pericardiectomy, stripping away the thickened, constricting pericardium to free the heart. It's a complex surgery. For some patients with transient or inflammatory constriction, a trial of anti-inflammatory medication might be considered first.
So often, heart health extends beyond the heart itself. Let's talk about peripheral arterial disease, PAD, and aortic disease. First, PAD affecting arteries usually in the legs.
Right. PAD is caused by atherosclerosis narrowing the artery supplying the limbs. The classic symptom is intermittent claudication, that's muscle pain or cramping, typically in the calf, thigh, or buttock, that reliably comes on with a certain amount of exertion, like walking a specific distance, and is relieved promptly by rest.
What are other signs?
Other signs on examination can include absent or diminished pulses in the feet, dorsalis pedis, posterior tibial, cool skin temperature in the affected limb, skin atrophy, thin, shiny skin, hair loss on the leg foot, and in more severe cases, non-healing ulcers or gangrene critical limb ischemia.
How is it diagnosed?
The initial diagnostic test is the ankle brachial index, or ABI. It's a simple, non-invasive test comparing the systolic blood pressure measured at the ankle with the pressure measured in the arm. An ABI ratio of less than a 0.90 is diagnostic of PAD. Values between 0.91 and 1.30 are generally normal.
What if the ABI is high?
An ABI greater than 1.30 is considered abnormally high and usually indicates non-compressible calcified arteries, often seen in patients with long-standing diabetes or chronic kidney disease. In these cases, the ABI is unreliable, and other tests like tube pressures, toe brachial index, or vascular ultrasound might be needed.
How is PAD managed?
Management involves several key components. Risk factor modification is paramount, especially smoking cessation, which is the single most important intervention to slow disease progression and improve outcomes. Also, managing diabetes, hypertension, and dyslipidemia aggressively.
What about exercise and medications?
Supervised exercise therapy programs are highly effective at improving walking distance and functional capacity. Antiplatelet therapy, usually low-dose aspirin or clopidogrel, is recommended for all patients with PAD to reduce the risk of MI, stroke, and vascular death. Cilostazol is a medication specifically indicated to improve symptoms of claudication, walking distance, but it's contraindicated in patients with heart failure.
When is revascularization needed?
Revascularization procedures, either endovascular, angioplasty or surgical bypass, are generally reserved for patients with severe lifestyle-limiting claudication that hasn't responded adequately to exercise and medical therapy, or for those with critical limb ischemia, rest pain, ulceration, gangrene, to prevent limb loss.
Next, abdominal aortic aneurysm, AAA, that ballooning of the main artery in the abdomen. Who is at risk and who gets screened?
The major risk factors for AAA are older age, over 65, male sex, and a history of smoking. Family history also plays a role. Because AAAs are often asymptomatic until they rupture, which is usually fatal, screening is recommended. The current guideline is for one-time screening abdominal ultrasonography for all men aged 65 to 75 who have ever smoked. Screening may also be considered for men in that age group who haven't smoked but have a family history, or selectively for women with smoking history family history.
How are AAAs managed once found?
Management depends on the size. Small aneurysms, typically 5.5 centimeters in diameter, are generally managed with surveillance, monitoring the size with regular ultrasounds, example every 6-12 months or less frequently depending on size and growth rate, along with aggressive risk factor modification, smoking cessation, blood pressure control, statin therapy, surgical repair, either open surgery or endovascular aneurysm repair, EVAR, is generally indicated for aneurysms larger than 5.5 centimeters, or those that are expanding rapidly, for example, 0.5 centimeters in 6 months or 1 centimeter per year, or if the patient develops symptoms attributable to the aneurysm, like abdominal or back pain.
And the very acute and dangerous aortic dissection, that tear in the aorta's wall?
Yes, aortic dissection is a true cardiovascular emergency. It involves a tear in the inner lining of the aorta, allowing blood to surge into the middle layer, media, creating a false channel or lumen that can propagate along the length of the aorta.
What's the classic presentation?
The classic symptom is the abrupt onset of severe, sharp, tearing or ripping chest pain, often radiating to the back, typically between the shoulder blades. Patients may also present with symptoms related to complications from the dissection extending and obstructing branch arteries, things like stroke, acute limb ischemia, acute kidney injury, mesenteric ischemia, or even acute myocardial infarction if the coronary arteries are involved. A difference in systolic blood pressure of more than 20 mm Hg between the two arms is also a highly suggestive sign.
How is it diagnosed quickly?
While a chest X-ray might show a widened mediastinum, the definitive diagnosis requires urgent advanced imaging, typically a CT angiogram, CTA of the chest, abdomen, and pelvis, or sometimes a transesophageal echocardiogram, TEE, especially if the patient is too unstable for CT.
How is dissection treated? Does it depend on where the tear is?
Yes, the management depends crucially on the location, classified by the Stanford system. Type A dissections involve the ascending aorta, the part arising from the heart. These are considered a surgical emergency, requiring immediate open-heart surgery to repair or replace the ascending aorta because they have a very high risk of rupture into the pericardium, causing tamponade, or extension into the aortic valve or coronary arteries.
And type B?
Type B dissections involve only the descending aorta, distal to the left subclavian artery. Uncomplicated type B dissections without signs of malperfusion or impending rupture are often managed medically initially. This involves aggressive control of heart rate and blood pressure, typically in an ICU setting, using intravenous beta blockers first, like labetalol or esmolol, to reduce the heart rate and the force of ejection, DPDT, followed by vasodilators like nitroprusside if needed to lower the blood pressure further. Target systolic usually around 100 to 120 millivili Hg. The goal is to reduce stress on the aortic wall and limit propagation of the dissection. Surgery or endovascular stenting, TEVAR, for type B, is reserved for complications.
And critically, what medications are contraindicated?
Anticoagulation, like heparin or warfarin, and antiplatelet agents, like aspirin or clopidogrel, are absolutely contraindicated in acute aortic dissection due to the risk of worsening the bleeding into the false lumen or causing rupture.
And you mentioned a connection to Marfan syndrome.
Yes, patients with Marfan syndrome, a genetic connective tissue disorder affecting the fibrillin-1 gene, are at significantly increased risk for aortic root dilation, aneurysm, and subsequent dissection. They require regular surveillance imaging, usually echocardiography, of their aorta throughout life, and often prophylactic aortic root surgery when the diameter reaches a certain threshold, often around 4.5.0.0 centimeter.
Fascinating how these conditions connect. Let's wrap up with some important cross-cutting topics in cardiology, things that often bridge multiple areas we've discussed. First, infective endocarditis, i.e., that infection of the heart valves or lining. What's a key diagnostic clue?
The classic hallmark, or at least the thing that should raise high suspicion, is fever plus a new or changing heart murmur in a patient, especially if they have risk factors like injection drug use, a prosthetic valve, or underlying valve disease.
How is it formally diagnosed?
Diagnosis relies on the modified Duke criteria, which combine clinical, microbiological, and imaging findings. The major criteria are 1. Positive blood cultures for typical IE organisms like Staph aureus, viridin strep, and Enterococcus from 2 separate samples, or persistently positive cultures for other organisms. 2. Evidence of endocardial involvement on echocardiography, which means seeing a vegetation that infected mass on the valve, an abscess or new dehiscence pulling away of a prosthetic valve. Minor criteria include things like a predisposing heart condition or IV drug use, fever 38 degrees C, vascular phenomena like emboli, Janeway lesions, immunologic phenomena like Osler nodes, Roth spots, glomerulonephritis, and positive blood cultures that don't meet major criteria. You need a certain combination of major and minor criteria to confirm the diagnosis.
What are some of the serious complications of IE we should worry about?
IE can cause severe complications. Heart failure due to acute, severe valvular regurgitation from valve destruction is a major cause of mortality. The infection can extend beyond the valve into the surrounding tissue, causing a perivalvular abscess, especially common with aortic valve endocarditis, which can burrow into the conduction system and cause heart block, prolonged PR interval, or higher degree blocks. And systemic embolic events are very common, where fragments of the infected vegetation break off and travel to distant organs, causing stroke if they go to the brain, splenic or renal infarcts, limb ischemia, etc.
When is surgery indicated for IE? Is it always needed?
Not always, but early surgical intervention, valve repair or replacement, is often crucial and indicated in several situations. 1. Moderate to severe heart failure due to valve dysfunction. 2. Evidence of uncontrolled infection despite appropriate antibiotics, persistent bacteremia, enlarging vegetation, development of abscess. 3. Prevention of embolism, particularly with large vegetations, 10-15 millimeter recurrent embolic events. Basically, if there's significant valve damage causing heart failure, if the infection isn't clearing, or if the risk of throwing more clots is high, surgery is needed sooner rather than later.
What about preventing IE with antibiotics before procedures? Who actually needs prophylaxis?
This is a really important area that's often misunderstood and overused. Current guidelines recommend antibiotic prophylaxis only for patients with the highest risk cardiac conditions undergoing specific high-risk procedures. The high-risk cardiac conditions are primarily prosthetic heart valves, previous history of infective endocarditis, certain complex cyanotic congenital heart diseases, unrepaired or repaired with residual defects or prosthetic material, and cardiac transplant recipients who develop valvulopathy.
And the procedures.
The procedures for which prophylaxis is recommended in these high-risk patients are primarily dental procedures that involve manipulation of gingival tissue or the periapical region of teeth, or perforation of the oral mucosa. It's also recommended for invasive respiratory tract procedures that involve incision or biopsy of the respiratory mucosa, like tonsillectomy or bronchoscopy with biopsy. It is generally not recommended for routine gastrointestinal or genitourinary procedures, like endoscopy, colonoscopy, cystoscopy, or vaginal delivery, unless there is active infection present at the site.
So much more restrictive than it used to be. Good to clarify. Now, perioperative cardiac evaluation for non-cardiac surgery, assessing heart risk before someone has surgery for something else. How is that approached?
The goal is to identify patients at increased risk of major adverse cardiac events, MACE, like heart attack or cardiac death around the time of surgery, and to optimize their condition beforehand if possible. Risk stratification often involves using validated tools like the Revised Cardiac Risk Index, RCRI, which considers factors like history of ischemic heart disease, heart failure, stroke, diabetes requiring insulin, kidney disease, and the inherent risk of the surgery itself. It's also crucial to identify any active cardiac conditions.
What constitutes an active cardiac condition?
These are conditions that warrant delaying or canceling elective surgery until they are stabilized. They include unstable coronary syndromes, like recent MI or unstable angina, decompensated heart failure, significant arrhythmias, like high-grade AV block, symptomatic ventricular arrhythmias, or uncontrolled supraventricular arrhythmias, and severe valvular disease, especially symptomatic severe aortic stenosis or mitral stenosis. Addressing these before non-cardiac surgery is key.
And what about using beta blockers routinely around surgery? You mentioned the POISE trial.
Based largely on the POISE trial results, routine initiation or aggressive titration of beta blockers solely for the purpose of non-cardiac surgery in patients who are not already taking them is not recommended and may even be harmful, associated with increased risk of stroke and overall mortality. Beta blockers should generally be continued in patients who are already on them chronically for established indications like angina, heart failure, or arrhythmias, but not started anew just for surgical risk reduction in most cases.
How about managing that dual antiplatelet therapy, DAPT, around non-cardiac surgery, that balancing act again?
It's a major challenge, balancing the risk of surgical bleeding against the risk of stent thrombosis if DAPT is stopped prematurely, especially after recent coronary stenting. For elective surgery, it should ideally be postponed until the minimum recommended duration of DAPT is completed, often 6-12 months after drug-eluting stent placement, sometimes shorter for bare metal stents or specific situations.
What if surgery is urgent or can't wait?
If urgent surgery is required while on DAPT, management is complex and individualized, involving discussion between the cardiologist, surgeon, and anesthesiologist. Generally, aspirin is often continued perioperatively unless the bleeding risk is deemed prohibitive by the surgeon. The P2Y12 inhibitor, like clopidogrel, ticagrelor, prasugrel, is typically held for the shortest possible duration. For example, 5 days for clopidogrel ticagrelor, 7 days for prasugrel before surgery, and restarted as soon as possible afterward when bleeding risk allows. But this is highly variable. And as we noted, P2Y12 inhibitors must be stopped 5-7 days before CAPG.
And severe aortic stenosis.
Severe aortic stenosis, particularly if symptomatic, is a major predictor of adverse perioperative outcomes for non-cardiac surgery. Patients with known or suspected severe AS generally require careful evaluation, often including cardiology consultation and potentially echocardiography, before undergoing moderate to high-risk non-cardiac surgery. Sometimes valve replacement might be needed before the elective non-cardiac surgery.
Okay, finally, let's touch on hypertension management. It's so common, but the guidelines and targets can seem complex. What are the general goals?
Current major guidelines, like JNC8 or the ACAHA guidelines, which are slightly different, generally recommend a target blood pressure. For example, JNC8 suggested 150-90 millimol of Hg for individuals aged 60 years or older and 490 millimol of Hg for those younger than 60, or those with chronic kidney disease, CKD, or diabetes at any age. The ACA guidelines aim for lower targets, often 180 millimol of Hg for many patients, but the optimal target remains debated, especially in older or frail individuals.
What about lifestyle modifications? How important are they?
They are absolutely cornerstone and should be recommended for everyone with elevated blood pressure or hypertension. They can significantly lower BP, sometimes as much as a single medication. Key modifications include adopting a heart-healthy diet like the DASH, dietary approaches to stop hypertension diet, rich in fruits, vegetables, whole grains, low-fat dairy, low in saturated fat and sodium, regular aerobic exercise, like 150 minutes a week of moderate intensity, achieving and maintaining a healthy weight, BMI 25, restricting dietary sodium intake, ideally 1,500 milligram a day, but at least 2,300 milligram a day, and limiting alcohol consumption.
And white coat hypertension. When the pressure is only high in the doctor's office, how do you confirm that?
White coat hypertension is common, where BP readings are elevated in a clinical setting but normal outside of it. The best way to diagnose this accurately, and also to detect masked hypertension, normal in office, high outside, is with 24-hour ambulatory blood pressure monitoring, ABPM. It provides multiple readings throughout the day and night in the patient's usual environment and is a better predictor of long-term cardiovascular risk than isolated office readings. Home BP monitoring is another useful tool.
Any special hypertension scenarios worth highlighting?
Yes, a few. Renovascular hypertension, caused by narrowing stenosis of the renal arteries, should be suspected in patients with sudden onset or worsening of severe hypertension, especially if resistant to multiple medications, or if accompanied by unexplained kidney function decline, or recurrent episodes of flash pulmonary edema, sudden onset severe heart failure with severe hypertension.
Hypertensive crisis.
Right, a hypertensive crisis requires prompt attention. It's important to differentiate between hypertensive urgency, very high BP for e.g. 180 or 120, but without signs of acute end organ damage, and hypertensive emergency, very high BP with evidence of acute ongoing organ damage, like encephalopathy, stroke, MI, aortic dissection, acute kidney injury, severe preeclampsia, eclampsia. Urgencies can usually be managed by gradually lowering BP over 24-48 hours with oral medications. Emergencies require immediate admission to an ICU and lowering BP more rapidly, but carefully, with intravenous medications. Critically, avoid overly rapid or aggressive BP lowering in most emergencies, as it can precipitate cerebral, myocardial, or renal ischemia. Gradual controlled reduction is usually key.
What about hypertension in pregnancy? Which meds are safe?
Managing hypertension in pregnancy requires specific considerations. Several antihypertensive medications are considered relatively safe. Labetal, methyldopa, and nifedipine extended release are often used. Hydralazine can also be used, especially parenterally for acute severe hypertension. However, ACE inhibitors, ARBs, and direct renin inhibitors are absolutely contraindicated throughout pregnancy due to the risk of fetal harm, teratogenicity.
Finally, common medication side effects, like with thiazide diuretics.
Thiazide diuretics, like hydrochlorothiazide, chlorthalidone, are effective first-line agents but can cause electrolyte abnormalities, notably hypokalemia, low potassium, and hyponatremia, low sodium, especially in the elderly. They can also slightly increase blood sugar and uric acid levels, so they're relatively contraindicated in patients with gout and should be used with caution regarding new-onset diabetes risk. They can also cause orthostatic hypotension, increasing fall risk, particularly in older adults. Calcium channel blockers, CCBs, especially the dihydropyridine type, like amlodipine, nifedipine, commonly cause dose-dependent peripheral edema, ankle swelling. Interestingly, combining a CCB with an ACE inhibitor, or ARB, can often mitigate this edema.
And ACE helps.
ACE inhibitors and ARBs are generally well tolerated, but known side effects include the potential for cough, much more common with ACEs due to bradykinin, angioedema, rare but serious, also more with ACEs, and hyperkalemia, especially in patients with CKD or those taking potassium supplements or potassium-sparing diuretics. A notable point: for patients with hypertension and gout, the ARB losartan has a beneficial effect of lowering uric acid levels, making it a particularly good choice in that scenario.
Wow, what an absolutely incredible journey through the vast and intricate world of cardiology, from deciphering the signals of a heart attack to understanding the mechanics of heart failure, from listening to the symphony of murmurs to tracking the rhythms and arrhythmias. We've really covered a tremendous amount of ground today.
We certainly have. It's a complex field, no doubt. Our goal was really to try and cut through some of that complexity, distill the key concepts, and hopefully provide you with a comprehensive but still digestible understanding of these core areas. We hope this deep dive leaves you feeling well-informed and maybe a bit more confident in grasping these topics.
Absolutely. I know I learned a lot just revisiting all this. So, as you, our listener, reflect on this deep dive into the intricate systems of the heart, maybe consider what surprising connection did you find between seemingly disparate pieces of information we discussed today? How might understanding these complex physiological interactions, the plumbing, the electricity, the muscle function, how might that inform your perspective on broader challenges or even just on the remarkable resilience and complexity of the human body itself?